Now, moving on to our next section, that is when the nerve recovery and functional assessment. In this, we will be dealing with what are acute nerve injuries and chronic, and how the nerves recover from acute nerve injury, and how do we assess the nerve function along with history and examination. What are the other investigations we need to do to assess the degree of nerve injury? Now, coming to the clinical features. Usually, it's associated with case of open fractures. Your neurovascular bundle is lacerated for maybe due to direct injury or due to the bony fragments which may lacerate them, and usually associated with vascular injury. There is maybe a numbness, paresthesia, and muscle weakness if the muscles are disrupted. Signs of abnormal posture, changes in the sensibility. For example, the patient is unable to sense different things. For example, 2-point discrimination is disrupted, touch and pressure sensation is disrupted. There may be a sudomotor changes. For example, there may be associated hair loss. There may be a vascular dysfunction. There may be associated with sweat glands abnormalities, and the skin may be frail and it's quite rough. Usually associated with dry skin and lack of sweating. Now, chronic nerve injuries are actually associated with mostly involve the muscular system, and this is usually the skin may be smooth and shiny. There's diminished sensibility. Eventually, if in case it keeps on as sensory pathways are disrupted, the patient is unable to sense anything with usually a sciatic nerve palsy. So what results is if there is a foot drop and the foot continues to hit some areas, there's maybe associated with foot ulcers, and there may be infective foot ulcers, the patient may not know about it because there was no pain which has been associated with these ulcers. So advanced stages may present with muscle hypertrophy or atrophy, and there will be muscle group wasting and postural deformities as well, because the ligaments, usually the feedback mechanism which is going back to the spine during the posture is disrupted. So this may be associated with bed sores, ulcers, or postural abnormality. Coming to the assessment, how do we assess how much the nerve is injured, whether it is a neuropraxia, whether it's axonotmesis, or whether it is neurotomesis? This is a lone injury neuropraxia. Usually it results in a mild compression of the system, although the function of the nerve is lost completely, but usually there is a recovery. And that recovery can be measured in form of a tunnel sign, which is peripheral tingling and dysesthesias. As we are moving upward towards closer to the lesion, usually this is the nerve shows some degree of function, and as we move away from the nerve, this usually shows more of a dysfunction. This is classically seen in tunnel sign, and by percussing over the area which is supplied by the nerve, this usually gives us a crude picture whether the nerve is regenerating or not. As told you, assess by percussing from the distal to the proximal area. Neuropraxia in the tunnel sign is usually negative, but in others it could be positive as well, like in axonotmesis. Other tests which are more sensitive and more specific for nerve injuries are EMGs, electromyography. There is a denervation potential if nerve supply is lost. This excludes neuropraxia because if a nerve is completely lost, there is no conduction, that means it's not just purely compression, then definitely it's either neurotomesis or it's axonotmesis. Although the EMGs actually mar the muscle fasciculations and muscle contractions to the nerve, so therefore it cannot exactly differentiate whether it's axonotmesis or neurotomesis. To exactly differentiate, we need nerve conduction studies for that. Coming to further, the assessment could be clinical as well, like 2-point discrimination, which can give us a crude whether this nerve is intact or not. Indication of nerve recovery. There's sometimes Merkel cells or Meissner corpuscles which actually detect the vibration sense. Simply a tuning fork can be used to assess whether the vibration sense is intact or not. And then there are other Steinman-Whitman tests and threshold tests which can be used to actually is for specific type of nerve pathologies to elicit and to diagnose whether what kind of nerve problem is there as well. Other assessment is logognosia, that is ability to localize touch. If the patient is able to localize touch, means that tract is active, or at least some amount of nerve function is present. There is another test called as Marburg pickup test, which actually measures the tactile gnosis of stereognosis of the patient. The patient is allowed to close the eyes, and if a round ball is being given in the hand, the patient is able to know whether it's some kind of a round object, or if it's a square object, he or she would know that it's a squarish object which is of this kind of a texture. Then in the chronic injuries, we need to grade the motor as well. How much, if it's a chronic injury, is usually associated with atrophy of the muscle, and muscle charting may be of paramount importance. Usually it starts from 0 up till, there are 6 grades from 0 till 5. If the worst possible score is 0, when there's no contraction at all after stimulation of the nerve. A flicker of activity if seen in the muscle is 1. Muscle contraction, if muscle contracts but unable to overcome gravity, that in the score becomes 2. If the contraction of the muscle is able to overcome gravity, then it becomes 3. And contraction against resistance is at least as muscle 4. A normal muscle power is actually 5. That is, that is able to move against the resistance as well. And if the muscle is the movement, it can be take place. If it only contracts but cannot move against the resistance, then it becomes 4. But if its contraction is against, not able to contract against gravity, but it goes with gravity, then it becomes 3 and 2, and gradually it goes down the grade. So ideal grade of a muscle is 5, but depending upon if it's a complete nerve injury, the muscle may be muscle power may be 0 out of 5. In this section, we have gone through how to assess a nerve injury. With all the history and examination, we can go certain clinical tests such as 2-point discrimination, touch and stereognosis, and vibration sense. Along with we can go for Tinel sign as well. And then there are specific tests for the nerve such as electromyographic studies and nerve conduction studies, which are more specific for the nerve which is involved. Thank you very much. Keep watching sqadia.com.